Rapid molecular testing in bloodstream infections has now significantly shortened the time it takes to find out the culprit pathogen and results of susceptibility testing. Whereas before, clinicians would typically have to wait several days to get this crucial information, now we're able to find out in the matter of a few hours. This means we now have the opportunity to more quickly de-escalate empiric broad-spectrum therapies to something that's more targeted and effective. Hi, my name is Simon Wu, and I'm a physician in the hospitalist division at the West Los Angeles VA.
Hi, I'm Dr. Matthew Getz, Chief of Infectious Diseases at the VA Greater Los Angeles Healthcare System and Professor of Clinical Medicine at the David Geffen School of Medicine at UCLA.
So I'm Dr. Christopher Graber. I'm Professor of Clinical Medicine at the David Geffen School of Medicine at UCLA and a staff physician at the VA Greater Los Angeles Healthcare System. I'm also the director of our antimicrobial stewardship program at the VA Greater Los Angeles Healthcare System.
Our article, which will be published in Mayo Clinic Proceedings, is titled "The Impact of Rapid Species Identification on Management of Bloodstream Infections. What's in a Name?"
I will say we're very pleased to have this article come out in the Mayo Clinic Proceedings. Because the article is written for a broad audience of physicians. We have authorship that includes a pediatrician, includes hospitalists, as well as infectious diseases experts, because we wanted to sort of make sure that we honed the message to make it comprehensible, understandable, and appropriate for wide use. And we hope to reach a broad audience through publication and through the work that we're doing right now and promoting leadership for this article.
So our article, which is organized by pathogen, provides information on the most likely sources of the bloodstream infection, suggests additional studies or interventions, makes general recommendations on primary and alternative antimicrobial selection, taking into account the resistance genes that are most commonly detected by these rapid test platforms. For example, the presence or absence of the MEK-A gene in staph bacteremia. It provides guidance on when consultation with infectious disease is recommended. And then finally, for most pathogens, we've also included a helpful pediatrics perspective on special considerations in this patient population.
It's really remarkable. And infectious disease is somewhat different than in other medical disciplines. Much of our therapy is empiric. We treat people based upon their signs and symptoms of the disease, where there's uncertainty sometimes as to whether a person even has an infection, but we want to be cautious and get ahead of the curve. And we certainly don't know in the vast majority of circumstances when we're starting therapy what the bacteria or germ is. We don't know, and we certainly do not know the antimicrobial susceptibility of that bacteria. And in the modern era, we have ever increasing prevalence of resistance amongst organisms and increasing diversity of mechanisms of resistance, which has led many providers to give very broad spectrum therapy to patients, particularly people who are at jeopardy of grave complications. And that's all well and good to protect people who are vulnerable. But what we want to do is identify the pathogen as quickly as possible, identify what antibiotics will work, and then minimize the breadth and potency of that antibiotic therapy so it's targeted just to that pathogen. Traditionally, that's taken 2 to 4 days to get the full information. But with the revolution in techniques being applied in the microbiology laboratory, we're now able to get an early information that tells us more than whether the organism is a gram-positive or a gram-negative or a coccus or a rod, but allows us to identify the genus and species and the presence of particular mechanisms of resistance.
A lot of the literature to date that's focused on the effectiveness of rapid diagnostics in improving antimicrobial utilization has shown that you don't really see the effect unless an antimicrobial stewardship program gets involved, notifies providers to say, hey, look, your blood culture, your patient's blood culture is growing this. This is the antibiotic you should use. And I think we can do better than that. I think we can empower hospitalists, we can empower inpatient providers to be able to look at that and say, hey, you know what? I know the empiric therapy to prescribe. Our other goal was to really kind of show some of the complexity that's coming out with the different rapid diagnostic platforms that are available. So we described 3 of them in the article, and different hospitals may have different ones. And there's differences in terms of the kind of targets that they amplify and what that means for clinical practice. Things get particularly complicated with a lot of the gram-negative rods. The different packages detect slightly different combinations of gram-negative rods. And so we wanted to basically show what the differences were and give examples for what one platform may show versus another.
But the data is oftentimes very powerful, allowing us to narrow down therapy. And what we're trying to do is empower the physicians who are at the bedside, the internists, the hospitalists and such, to make decisions based on information. Because what's been found is that in many circumstances, that information is not acted on when it becomes available, such as 24 hours after cultures are obtained, but only after another day when the infectious disease team or others get involved.
One of the things that's clear is that we're running out of antibiotics. There's some organisms that are actually highlighted in that table 3 where there are good treatment options. There's kind of some arrows that say, well, consult infectious diseases, because we're not entirely sure what to give here. And so anything we can do to promote the effective use of the antibiotics that we do have is going to be critically important. And we're hoping that hospitalists in particular can use this guide to really promote proper antimicrobial utilization at their institutions.
It's important for the frontline providers who receive these rapid test results to first feel knowledgeable, to feel confident, and to be comfortable with how to appropriately act on them. We hope our article will help hospitalists and other frontline providers to better leverage these rapid diagnostic tools in their own practice so that they can make more timely decisions in tailoring or de-escalating their antimicrobial choices in the management of bloodstream infections. Thank you for listening.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.